Hello and welcome to the next episode of the Psychedelic Medicine Podcast. I'm Dr. Lynn Marie Morsky, your guide on this journey, and today we're going to be revisiting an old episode where myself and Dr. Mark Braunstein talk about the dark side of ketamine. This was a really important conversation we had years ago, and as I'm sure you've seen in the news, a lot of things have happened since then, and I am very excited to have Mark back on to revisit that conversation and talk about some of the things that have happened in the interim and more things to look out with regarding ketamine use. Now, before we get to the episode, just a reminder that the Psychedelic Medicine Podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And one more reminder, if you are a clinician and you'd like to learn more about psychedelics and how they may benefit your patients, please check out the Psychedelic Medicine Association. It is our mission to educate you on all the different psychedelics, their uses, their indications, contraindications, and ways to speak with your patients about those psychedelics. So if you are interested to learn more, please check out psychedelicmedicineassociation.org. Now, without further ado, thanks so much for joining us again today, Mark.
Good to see you, Lynn. Thank you.
Absolutely. Now, as I said in the introduction, a lot has happened since our last recording. That might have been in like 2021, I think. It was probably 3 years ago. And I was so glad that you reached out to have this updated conversation. Can you talk about, in the past 3 years since we initially brought this up, I think a lot of the things that you were concerned about have actually come to fruition. I think you had talked about the potential for ketamine addiction and some other things. So just to kind of start off, like, what are some of the overarching things that have happened in the past 3 years that we should keep on our radar when we're considering ketamine use?
So in the past 3 years, what I've noticed and why I reached out, Lynn, is my concern with what I've seen with patients, some friends, and some colleagues who have developed problems with ketamine. Some who have gone through treatment successfully, some who have not, some are in denial. And so really what I was talking about theoretically with concerns several years ago, unfortunately has manifested. And it's of great concern to me because I love this medicine. I believe in this medicine. It's a beautiful medicine, and it certainly has a dualistic nature.
Yeah, absolutely. And I'm glad you brought up the fact that you have seen a number of colleagues struggling with this, because I think a lot of us would kind of assume, oh, this must be patients we're talking about that maybe were prescribed it and then began to abuse it, like we're used to with something like an opioid scenario, or maybe we're talking about street use. But this to me is kind of akin to where in medicine we see significant issues with people in anesthesia or other anesthesia related specialties developing certain drug use disorders in regards to the medicines they have access to as an anesthesia professional. And I think that's kind of what we're seeing with ketamine, if I'm reading you correctly on that.
The access is definitely an issue. And then I think just thinking about why people get into the healthcare professions and how the message of ketamine resonates with that, right? Through ketamine, we understand connectivity and we want to, we want to help others, right? We have this connectivity to the planet, to others, and then ketamine lets us know how we can help, right? So it kind of feeds that the reason why people go into medicine or into mental health. We want to help people. We want to help the world. We want to help make this a better place. And then for some people that have a taste of ketamine, that message really gets strengthened. And so then it goes hand in hand, and they believe that they're doing a good thing, and they're getting these messages from the ketamine and the downloads from ketamine of how to help. So then they get stuck in that message, in the delivery of the message.
Yeah, absolutely. Let's take a step back if we could. Can you talk a little bit about why, if we know why ketamine, the molecule, has these addictive potentials?
So what I was just talking about, that feeling of grandiosity and that feeling of super intelligence and that euphoric state that ketamine gives us and can bring someone out of a depression, that can be addictive in and of itself. So I think that's what we're looking at more than the molecule. It's the psychological effects of the molecule that are fostering that addiction and dependency, right?
And I think that's interesting, along with the fact that I literally just yesterday had spoken with somebody who is a patient advocate for those with depression, and he very candidly said, like, prior to the procedure that had actually stopped his depression, he had tried ketamine therapy and he was put on some at-home nasal spray, and he said, when you want to take your life every day and ketamine is the only thing that's making you want to take your life less, those 8 squirts you're supposed to take might turn into 12 squirts because suddenly, like, oh my god, it felt so good to not want to take my life, but it's starting to wear off, and the supply wasn't lasting as long, and those kinds of things. So I see there might be a number of reasons why that the good feeling could lead to people using more than prescribed or than maybe advisable.
Because then it's overshooting the mark, right? You're not just looking for resolution of your depression, but you're looking for continuance of that euphoric nature, that grandiose nature, almost a hypomanic quality to itself. So people don't stop at "I'm better," right? You get to
Well,
"I'm
or
better," then
they
it's
Yeah, or they get to better, but it wears off, right? Ketamine wears off quickly, and if you're
yeah.
given a certain supply and you're told to do this once every week, but your depression is back 2 days later, it's hard
Can
not
we
to think like, can we do this again?
Well, and this is where can we please talk about best practices, right?
Yes.
How can we facilitate the ketamine to work the best for people so it doesn't wear off, right? So
Yes.
my goal when people come to see me is I don't want you taking this forever. My goal is for you to get better and never see my face again, right? Um,
I
not
think
the
that's right.
greatest in the
Right, where ketamine therapy
for-profit,
comes in. Right, right.
but that's what's really beautiful about this medication and psychedelic psychotherapy is that we can grow and we can actually get better and have resolution sometimes
Yes.
rather than
Yeah.
fostering dependency on psychiatric medications.
Right, because as we know, ketamine opens that critical learning period for about 48 hours following the journey, the ketamine journey. And why, if you're not making the most of that period with some psychotherapy, with integration, all of those things, you're right, the effects aren't going to last. But if you are making the most of it, I think, like you said, we're going to decrease the likelihood you're dependent on the molecule itself, which is what is going to lead to these more addictive or abusive behaviors.
It's a little bit tough because we're fighting somewhat of an uphill battle with our population because what is psychiatry? Overall, what have the message we've sent since Prozac has been if you take this, you'll get better, right? And trending away from psychotherapy, away from some self work and towards reliance on a medication. So, how can we break out of that as
Yeah.
clinicians instead of fostering that?
Right, absolutely. Now, can you talk a little bit, like you said, you've seen this firsthand in colleagues, patients, et cetera. Can you talk a little bit about what ketamine addiction looks like?
Yeah, I mean, so I think first we look into frequency of use, and I haven't, there's two types of abuse or dependence that I've seen, and the one is episodic binge type, and the other is chronic daily use. Most of what we see in abuse and dependency is the chronic daily use, but there are some binge type people too, and so I've seen them both.
Yeah. And is there a scenario where, and I know that, obviously this is going to come up, but like a Matthew Perry situation where we know he was getting ketamine prescribed, right? Like I think there was like in-person ketamine that he was doing, but then obviously that's not the ketamine that was leading to the at-home use, right? So is there a scenario where, like with opioids, the initial might be prescribed and then it leads to having to find it in different ways?
Yeah, I mean, so I recently had a client who had great improvement with intramuscular ketamine-assisted psychotherapy, and when that course of psychotherapy, and he was still actually in the course of getting ketamine-assisted psychotherapy, went on a holiday, and someone introduced him to street ketamine by nose, and right away it sucked him into daily use. right away, and I heard from him a few weeks later, at the point where he's using every day. And what do I do now? Right? This medicine saved my life. This is the thing that is keeping me from feeling suicidal. It helped me. I got better, and now I've got a monkey on my back.
Yeah.
Right?
And what do you tell patients in that? Like, what can be done in that situation? Like where you said, like, how do they walk that back? Do you have to go cold turkey? What does it look like?
So I'm going to be careful with my wording here. But in this client, there might be other there might be other plant medicines that could help this person, depending upon where they lived and legalities, of course. But ketamine isn't the right one for everyone, and we can get similar type work from other medicines as well. And that is a nice quality of the other medications. Not that they can't be addictive, because you can most certainly become addicted to plant medicines, but the incidence is so much less than with ketamine.
Yeah. And so physiologically, does ketamine addiction have withdrawal like we see with opioids?
Not well. When you say no, not like opioids, not like alcohol, not like benzodiazepines. It's mostly like cannabis, a psychological with psychological withdrawal syndrome. Right, with cravings being the biggest problem, and that's what I hear. I went to bed not wanting to do ketamine again the next day, and then I woke up and I just couldn't make it through the day again without ketamine. So kind of getting into that cycle.
Yeah. And when you said that people have gone through treatment, that's what you're referring to.
Yeah, rehab.
Yeah.
I've sent a couple of people to rehab, and they came out successful after a 30-day treatment. I say successful. They've had over a year or two of sobriety since then. But
Nice.
yeah,
Have you, I was going to ask because I know that on the intake for ketamine that it's asked if a patient has a history of any addiction. And I was wondering if there's any correlation that you've seen.
So here's what's scary to me about ketamine is that these people that I've seen having problems um, are largely lifetime recreational psychedelic slash drug users without problems. And these are people that have made it to age 50, smoking, tripping a little bit their whole life without having a problem. Then at 50 years old, find themselves hooked on something for the first time. So that's what's interesting, right? And of great concern is that they've made it through many years of dabbling recreationally, but this one they couldn't break free from.
Yeah, that is interesting. And we have done episodes before on ketamine for alcohol use disorder. So, there is a role, right? Into other.
Absolutely. Because just because they come in, they have on their intake form a history of dependence or even current dependence. That's not a rule out. It's almost an indication for if they're looking for change. Right. So that's the primary differentiation I make when I'm treating patients with substance abuse is, do they want to change? Are they coming to me and motivated to get change? If so, fantastic, we can possibly proceed. If not, no, this is not a medicine for you.
Yeah, very good distinction. And I think that and I know that we discussed this with Dr. Mandel when we did the alcohol use disorder episode, is like, we're not talking about at-home treatment for these patients. We are not, we are talking much more monitored situations. And I think, like you pointed out, that the danger is when that crossover happens, right? From the in-person monitored to the
at-home model.
Use.
And then you see with the at-home model, there's a company doing daily. It might not even be just one company, but there's daily. Ketamine is not a daily medication. I mean, maybe in some extreme cases but as a general rule, to make that a business strategy of daily ketamine I really believe is criminal.
I saw that and was equally as appalled as it showed up on my Instagram as an ad. I was like, oh my God. Yeah. I'm on the ketamine task force. I was like, has anybody else seen this ad? Yeah, very, very concerning. So let's talk a little bit about some of the other, like you said, there are reasons that people use it because they, start feeling better, this and that. But then there is that other darker side where it starts to tip into, oh, I'm feeling so good and so connected that are we looking a little bit of messiah complex, a little narcissism?
And to be fair, also, many of the people that I've seen develop ketamine problems weren't coming from a clinical population. They weren't coming from treatment for depression, right? They were coming from experimentation with another recreational psychedelic that just went sideways.
That's good. That's a great distinction to make, because, and I think you maybe what you said about those coming in wanting to change with alcohol use disorder is the same. Like if you're coming in desperate for help with something and you're finding it's helping you, why would you want to risk this addiction potential?
Especially if you're given education about it up front. So that's the other thing that's changed in my clinical practice so much from when we first did the podcast a few years ago, is now an implicit part of every evaluation I do is giving strong informed consent about the addictive nature of this as well, so that people really understand it going in. Because if you look back at the opioid crisis, in my mind, what largely created that was a lack of education physicians gave their patients, right? They give them unfettered access to a medication without a warning of the potential risks. And that's a recipe for disaster. So for starters, I know I'm jumping around, but for starters with ketamine, can we please do that? Can we please educate our clients and give them informed consent so they know? So at least it's buyer beware.
Yes, great point. And I think that's such an important point, because we kind of tend to loop all the psychedelics, like lump them together. And okay, most do not have, like you said, a likelihood of addiction to develop, but ketamine is the one that does. And we should make sure to point that out. Like there are a lot of things that are different about ketamine from the others. Much more short acting, easier to obtain, easier to kind of do in a scenario where it's, we see the Silicon Valley people doing it, and it became like the
Performance
new microdosing.
enhancing.
Yes.
And it's not a microdosing medication. There is no, so here's another thing. There's no such thing as ketamine microdosing, right? Like, because you think of microdosing as sub-perceptual. Everyone that's using everyone I've met that has abused ketamine, it was not a sub-perceptual effect. They were very much abusing it to have that perceived effect. Maybe not a psychedelic effect. Usually an intoxicated, wonky effect is what they're going for. And people refer to that as microdosing. It's not microdosing. It's
Thank you for
abusing
that
small doses.
Right. Yes, absolutely. And if you could talk about some of the dangers, and I think in this situation, and correct me if I'm wrong, but the dangers, like you said, with colleagues who abuse it, and some of those colleagues are the ones treating other people, this can all kind of perpetuate. So can you talk a little bit about the dangers of like this narcissism messianic complex that can come up in those, especially those who are, wanting to be, let's say, quote unquote, healers for others?
Yeah, well, I mean, I think that if we wholeheartedly believe in this medication and don't give out the risks, that's part of it, right? We have to have a balanced way of looking at this medication. And if we're looking at it in a very grandiose, I'm going to save the world with ketamine way, right? We're not looking at the flip side and the dark side. We're not giving patients the whole truth about ketamine. And that's really what we should do, is give them the whole truth, not like an isolated, grandiose way that then we're helping to propagate their problems, right? Because we're representing it as performance enhancing and all these other wonderful, great attributes. And if people only hear that, well, then why not use it every day in small amounts, right? When Elon Musk gets on and talks about, regular use of ketamine, and he's so successful, then other people see that. Well, I want to be like, if Elon's doing it, right? And I think we do, as it's become more popular in higher echelons of society, that people look up to, that's made it more dangerous as well, I think.
Yeah.
Right?
And for anybody who's interested, we've done at least one episode on psychedelic narcissism, and then we did a second one on avoiding the traps of psychedelic self-absorption. And I think they're both kind of in that same vein where, and I think, like you said, a lot of it comes from that like connectedness feeling, like, well, I'm so connected to all these higher things, right? And like, if you don't keep yourself grounded and you're constantly going back to that connected higher place without anything tethering you to reality, that can lead to a pretty dangerous situation.
Warning sign: if someone's talking about saving the world, too much. Like, there's nothing wrong with wanting to save the world, but kind of listen to that grandiosity, how it's being presented.
Right. I guess, here's a good question that maybe could help patients who are in search of a ketamine provider. What would you suggest they look for?
All right, so some good folks over at the Ketamine Research Foundation, some a group out of that. We came up with a capstone clinics. So we trying to create um, the the standards, the greatest standards of how we believe this medication should be treated, inviting clinicians and clinics that fall into this model of providing CAP and really believing in ketamine-assisted psychotherapy to set that bar and then hopefully educate the population so that the population knows this is what I want to do, not just an IV clinic, right? So how can we create those standards amongst ourselves? And yeah, so that was the idea behind Capstone, to kind of create what we believed the best model for getting this medication out and avoiding the more irresponsible manners of getting it out.
Yeah. And so what are the things that in your, certification that is upcoming that like people could at this period look for in a potential ketamine provider?
Non-drug only. I mean, to keep it really simple for the people out there, if your provider is offering only the drug, well, that's not the greatest fit for everyone, but then it gets into from the client's point of view, and I deal with this all the time. It gets into the client. How do we help the client to make an appropriate financial decision? I think that's a rough one, right? Because if they're looking at, well, the CAP model is going to cost me 600 a session, or the IV is going to cost me 450 a session, and then how do we want everyone to get help too? So we don't want to say no. If you won't do CAP, you can't have help. We want to educate and try and funnel people into the right way of treatment. But at the end of the day, if they'll only accept a subpar treatment that is still going to save their lives, I'm in favor of that.
Yeah.
Listen, I want people to get better, and if they're absolutely opposed to doing it in a therapeutic context, I still want them to get better. But let's educate them about the risk. Let's be prescribed. Let's be um, safe with how we prescribe it. Let's not give them a prescription for the next year for taking ketamine every day at home unsupervised, right? Like, let's not give them unfettered access to IV centers. Like, it's great that they're coming back and signing up for once a week for the next year for your financials, but is that best for the client? So how can we be responsible professionals? And this is where really, we get into talking about the economics and economic countertransference that we have towards our pay, and being real about that we never discuss in psychiatry, at least. But how does that dependence affect our bottom line, and are we encouraging it because of an unconscious need to pad our pockets? So really being aware ourselves as practitioners is giving the best model of care to our clients and thinking about our clients first.
Yes. And I love that you brought that up. And as you're talking, it just occurred to me that I did not read your bio at all. Dr. Braunstein is a child, adolescent, and adult psychiatrist and psychedelic specialist. Sorry, I completely forgot that because I was just so stoked to get to our conversation. But Dr. Braunstein is coming from psychiatry when he says these things about the psychiatric incentives that are there. And when I see I worked for an at-home ketamine place very briefly. And when I signed up, the reason they brought me on is because I questioned their model and they said, okay, come on and make it safer. And the first thing I said is anything that comes in a package, I'm leery of, because what if somebody's better after 2, but they've paid for 6?
Yeah.
Then are you going to give them the rest back? Or are you encouraging just extra use,
Totally. Yeah, no, I mean, I would encourage more the full package, because I want them to go through a therapeutic process and have a full benefit and not come back to see me forever. But I but you do want to
Very
give,
fair. Yes.
but I do hear what you're saying as well. Like, if someone is better at 2, can we stop? Do we have to keep going? Do we have to sign them up on a package for the next year?
Right, right. Like, yeah, there's some intermediate between, those two things, right? Like,
Right.
what is the maximum amount of benefit we can get in the minimum amount of sessions, and let's keep the
You,
packages to that.
you just said a very important word, reasonable. What's a reasonable midpoint?
Yeah.
Lynn Marie, if we can find that, like that. And so,
Yes.
and so that's where we try and come in with what is a reasonable intermediary, and how can we make ketamine-assisted psychotherapy more affordable for people, so it doesn't have to be a huge upcharge. And when you can relay it to them in the terms of economics of, well, you're not going to be coming back, hopefully, in 6 months for another six, then it can start to make sense and click for people why it's better. But it is tough sometimes when you're selling something for a $4,000 package without versus a $5,000 package with. People are going to want that for. Well, the best we can do is educate, and trying to be aware of the pitfalls of psychiatry over the last 4 decades and not recreating that with ketamine and then having to say goodbye to ketamine, like we've said goodbye to opiates now, and people are leaving surgery unable to get opiates. We don't do a reasonable middle ground very well in medicine or America.
Yeah, that's very true. Very true statement. I was thinking about you talking about before, like, okay, other things to look for besides the, but I also wanted to throw this in, is that when we're talking about affordability, Enthea is trying to get, and I know they're not alone in trying to get more employers to cover CAP or ketamine assisted psychotherapy for their employees. So like, hey, if you are first off, if you work for Dr. Bronner's, you're covered, like they're the luckiest, but like,
Totally.
Ask your employer, tell them that's important to you, start that conversation so that we can, like you said, find more ways to get this covered.
So I'm the psychiatric director for New Path. It's a CAP clinic model. And one of the things we're trying to do is reach out to companies in our area and let them know what we're offering. And yeah, so that's a great way of doing outreach to these companies for employee assistance. How can we get involved with that?
Yeah, absolutely. So what I was going to say was, when you're talking about, patients looking at a potential provider, in addition to the fact that, like, make sure that the only, hammer they have is not ketamine, right? Like they say when what was the thing? Like, if you only have a hammer, everything's a nail, right? Like, make sure that they have multiple modalities, that they're not just giving you ketamine because that's the only option. And then secondly, what are some of the maybe just interpersonal personality characteristics that you would recommend people look for?
Let's get to that, but let me cover the
Okay.
first part, which
Yes.
I think was a really important question, because when we talk about what to look for in a provider, like, you're going in for help with your mental health. Why are you seeing an ICU doctor or an anesthesiologist with your recurrent treatment-resistant depression or bipolar 2 or your severe OCD or your severe addictions? It's like, if I need anesthesia, I'm not calling a psychiatrist to put me out. If you need help with suicidality, why would you go to an ICU doctor?
I love Mark. You just can call it like it is. By the way, everybody should be watching this one on YouTube. Mark is so animated. I love it so much.
But no, I mean, I really do think if you're going, the first thing to look for is, how about a psychiatrist, right? And then what you point out, not having one tool. So like, you go to an ICU doctor for your depression, everyone's getting recommended ketamine. I would scratch my head. When someone comes to see me, they're getting a very comprehensive, thorough evaluation from a psychiatrist who wears multiple hats. And I'm going to give you based upon you, what's best for you. And it might have nothing to do with ketamine. I saw someone 3 weeks ago, and I wanted to recommend ECT. I stopped short of that, went with an antipsychotic. But like, if I wasn't wearing that hat, and this individual had been through a year of plant medicine with what I think was a very inappropriate provider who kept throwing different medications into the person, who were watching them worsen over the course of the year and telling them, this is your psychiatric medication withdrawal that you're experiencing, rather than giving a semi-psychotic person ayahuasca, psilocybin. I mean,
Oh
I can't
boy.
even remember the litany of everything that this unlicensed person had put this client through. I got lost in what you were asking me. I'm
That's
sorry
okay.
with
I
that
still like
tangent.
the rant. That point was that go to preferably somebody who is trained
mental
to
health
deal with your mental health.
specialist.
Right. So that ketamine isn't your only option, because maybe that's not for you, but you're definitely more likely to be given it if it's not for you, if there's no other option that they have to give.
Totally. And you're coming in desperate saying, please give me this. I'll sign you up.
Right.
Without
Absolutely.
psychotherapy, without integration.
Yes. All of this. And yeah, I just love talking to Mark so much. There's no dearth of passion. Seriously, go check this out on
Totally.
YouTube. But we were talking about, like, some of the, I guess there's one thing you want to look at the positive signs, and then what are, so maybe if you give some of the positives look for in a person, like personality wise, and then maybe some of those warning things, like if they tell you they're going to save you and the world, probably run. But like, what are some of those maybe interpersonal personality characteristics in the provider that you think would lead a patient to feel safe and probably be safe with that provider, versus one where you might suggest otherwise?
I think it comes down to the patient. They're going to meet with that provider and they're going to know how they feel sitting across from that person. Is that person creating a safe a container of safety and sanctuary for them or not? And if you don't feel 100% safe with that person, don't go with it, because it's going to affect your ability to have a positive treatment. Your ability to drop in is really, and when I say, I'm sorry, your ability to have benefit from this medication is directly relatable to the decreased anxiety you're going to have going in for treatment.
Yeah.
You want to be as comfortable as possible. And so if
Yeah.
someone being grandiose and talking about saving the world makes you feel relaxed and calm, well, they might not be the worst provider. At the end of the day, they're giving you a dose, like, and again, if you're educated on your own about ketamine and its dangers as well, you don't need that provider as much. So a lot of this again is buyer beware and patient education ahead of time. And if so, an educated patient going in to see that provider, then they can make up their mind. But I think safety is most important. Um,
Yeah, I think you made the point earlier. Like, if that provider does not mention any of the dangers of ketamine to you beforehand, you're not getting informed consent. And I think that, we wouldn't go into a surgical procedure with a surgeon who hadn't given us informed consent.
and
And I,
asking their opinion on that, asking their opinion on ketamine. If someone tells you, "Oh, there's no potential for abuse, no potential for dependence," how are they going to be prescribing it to you? And are they going to be prescribing it in an unsafe manner that kind of encourages your abuse? So I think really this person should be reticent and not so overly hyped up to get you signed up.
yeah, very good point. Now let's get to the nitty gritty. If somebody's listening to this podcast and they feel they may currently have an unsafe relationship with ketamine, what would you advise them to do?
Who can they talk to about this? So, not keeping it a secret for starters. Can you talk to your spouse about this? Can you talk to your clergy about this? Can you talk to your therapist about this? Do you need to find a therapist to talk to about this? Right. So, talking with someone, having an accountability group also, so I think that part of the problem with an accountability group is it depends who your group is. If you're in a group with five other providers who all are kind of had grandiose small ketamine problems, they're going to be encouraging that use. Like, what download did you get last night? Oh my God. I, and so you have to really be, you want to be with a group that has its head on their shoulders and can talk about ketamine abuse and admit that it's there. Um, yeah,
Yeah,
not just other like-minded ketamine heads.
I think that's, people listening to this who may not live in this soup, do not realize how true that last statement was, because it's so prevalent that you would have no problem finding five people to make your problem seem like actually just very beneficial, right? Oh, you connected every night. You got a great download. Way to go. Bet your patients are so lucky. It's like, this is just the blind leading the blind down a very dark path. And
So what do I see that makes me concerned with someone that I'm talking to, a clinician or a client, is that grandiosity. So that's going to be a real That gets me concerned right away when I hear about these downloads, right? Because that's where you get not just that's where other psychedelics you can have dependency too, right? Like, and you see people with those the releases, right? They go for Aya ceremonies every week after week after week, and what's going on, right? So there can be an addiction to the download or to the release.
Yeah, and to that connection and all the other things. And then we discussed this. I had Sonny Strasberg on a few episodes ago talking about going slow to heal faster. Like there is no healing Olympics where somehow it's beneficial to just like nail your neurologic system with these massive doses all the time, or even these smaller doses, but daily, because you got to get that download. You got to, it's like the spiritual Olympics. Who's, reached talk to God more this week. It's very harmful mindset.
And the people I know that have been successful in this line of work from a patient standpoint, whether they're a clinician or not, have been the ones that have embraced the work. And that just knowing that this is going to be this is a process and I'm in it to win it for life, right? That I'm working on myself.
Yeah, absolutely. Mark, we could have this conversation probably every 5 minutes. I'd be so happy about that. But because I just, I love the passion you bring to protecting people, like these are not easy conversations to have. And it's really difficult because ketamine, like you said, such a beneficial medicine that it's, it's so hard for people to sometimes acknowledge the dark sides of something that has saved so many.
And because here's what I want to add, the people who have it's very rare that people come to me complaining of a ketamine problem. It's more that I get a phone call from their spouse. What do I do? Because it's hard to break out of that grandiosity, that hypomania when you're in it. It's usually the spouse.
Interesting. Okay, well, for any spouses out there who've seen this,
reach out to their doctor.
Yes.
Reach out to the provider. Let that provider know because they don't need a release of information to take information from you. You're allowed to call your spouse's provider and let them know what the concern is.
Thank you for that. I'm sure that is going to help a lot of people with this. So thank you for all the wisdom you've provided. Can you tell people where to find out more about you and your work?
Yeah, right through New Path Clinics or through the Ketamine Training Center are fantastic ways.
Do you have any URLs you'd like to share with us? New Path Clinic have a URL. Just Google it, guys. That's right. Nobody uses URLs anymore.
I'm not selling anything. I'm not selling myself.
I love Mark.
If you want to find me, come and find me.
That's so cute. I'm just trying to help out our show notes guy, but you know what? He'll give you it. It's good. We love you, Jared. Dr. Braunstein, thank you so much for your years of passion and dedication to helping people in this way and for your candor, because it's my favorite. So thanks for coming on again.
Thanks for helping us all out.
I appreciate it very much. All right. For everybody else out there, until next time.